Hello, everyone. Welcome to GBMC's Greater Living. I am Mary Beth Marsden. We are coming to you live. Thanks so much for being here, if you're joining us online, and also if you're in our studio audience. We've been talking today a lot about the voice and the importance of your vocal cords. I think now we're taking a little bit more of a serious turn and talking about head and neck cancers. And joining us now is Dr. Ray Blanco, who is a head and neck surgeon at GBMC Health Partners Otolaryngology, and he is also at the Milton J. Dance Head and Neck Center, and he's an expert. And so this can be a big umbrella when we're talking about head and neck cancers of a lot of subsets, as you pointed out to me earlier today. So let's just take the broad view and talk about, Dr. Blanco, what exactly is considered head and neck cancers, and you can name some specific ones.
So the definition of head and neck cancer in our specialty, you have to really place it in a certain anatomical subsites. So the oral cavity, for example, is divided into thirds. Anterior 2/3 is the oral cavity of the tongue, buccal, gingival, and floor of the mouth, lips. That's the oral cavity. So the circumvallate papilla is the one that separates that thing. Beyond that, which is the anterior pillars, tonsils, soft palate, base of the tongue, and portion of the posterior pharyngeal wall will more or less compose the oropharyngeal region. Then you go down, you have the supraglottic area, that means above the cords, and you have the glottic area, which is where your voice box is generated, and the subglottic area. Then you have your larynx, the whole larynx. Then you have your trachea, your thyroid, the cervical esophagus. When they say define cervical esophagus, from the cricoid level, the entry where your food comes in, down to up to the level of the sternum. That's the cervical esophagus.
Yeah, we talked about that. Esophageal cancer is considered a head and neck, and you said right until this point at your sternum.
Yeah, because there's a different format. If you review the literature, most of the data are predominantly thoracic esophagus, but the cervical esophagus is a unique one that's in our area of specialties. So we also take care of thyroids, the maxillary sinus cancers, and skin cancers in the region of the head and neck. Skull base is a specialized types of head and neck cancers in which I recommend, if you have a skull base tumor, to go to an institution.
Are most head and neck cancers carcinomas? You mentioned skin cancer, and that's why I don't know if people often think of that.
Yeah. So when you say cancer, it's an interesting question because that's a common question. When you say malignancy, to the patient I will say, look, cancer malignancy is more or less similar. When you say tumor, you don't have a definition whether that thing is benign or malignant. That's a very important point because patient will come in saying, I have a mass here. Is it benign? Is it malignant? When they say, sometimes the common knowledge is, I have a tumor. They think it's immediately malignant. You have to reformat or reorient the patient saying, look, we don't know what this thing is. You need to have a black and white report to say that this is malignant or benign. That's usually immediately refocuses the patient because patient will come into a head and neck cancer center and they say, I have cancer. No.
What they really mean to say is, I have a tumor.
What they mean to say is either proven cancer, they have a mass, they have a symptom, all suggestive going to head and neck cancer.
But I get taking that leap. I think we've all kind of, diagnosed ourselves when something's not quite right. Mm-hmm. Out of all those areas you mentioned, which is the most common that we see as far as head and neck cancers go? So the one that's really concerning us right now is the HPV. Because if you review the epidemiologic data. And that's the human papillomavirus.
The human papillomavirus. So before, the data for the United States is 70 to 80% for oropharyngeal. When I say oropharyngeal, the anatomical side is the base of the tongue, anterior pillars, posterior pillars, tonsils are predominantly triggered by HPV. Before, several decades back, it's triggered by smoking and drinking. There seems to be a shift now epidemiologically. It's now 70, the range is 70 to 80, at least triggered by HPV virus, and the remaining now is smoking and drinking. So that's the one we're seeing frequently. In fact, if you review some of the literature right now, HPV will bypass or even go beyond the cervical cancer cancer for female by 2020. So it's an issue right now.
Wow. So, and just, you're probably aware that children now are getting vaccinated for
HPV.
So do you see down the road that this will be eliminated?
Okay, that's a very common question by the patients. In fact, when patient comes in, they think about their children too. First thing is that it's given before 15 and sometimes as late as 26. Notice I'm giving you the range. So the question is, will HPV vaccine can be considered as treatment? The answer is no. It's used for prevention. Okay. What CDC has placed is that using this, it prevents their projection. The data projection is that it will reduce head and neck cancers by 33% because they're targeting a specific type of virus, the 16 and 18. So if they prevent that early, the projection is it will reduce it by 33% in the future, which is actually good for us.
Yeah, but there are other types of HPV, is what you're saying.
Yes, there are other
This is just
types
one
of
specific
16 and 18 are predominantly the serotypes that triggers the oropharyngeal cancers.
So someone could have this HPV for a long time, and then it just sort of mutates into a cancer much later in life. Is that the feeling?
Okay.
Or are we triggering it with alcohol and cigarettes?
All right, that's a different topic. Let me subdivide it. Let's subdivide it
We need
first.
more time, Mindy, I think.
So actually, that's a good question. In fact, there's a paper that came out in the NCI that concerns that. So let me first address the HPV issue. If you review these sexually transmitted or infectious disease journals, they will consider HPV as a sexually transmitted disease. In fact, they say for sexually active patients, 1 out of them will have it. The question that the patient will come in is that, if I have this, will it go to cancer? Then you have to reassure the patient in a very layman's term. And I usually tell them, look, it doesn't mean if you have HPV, it will turn to cancer. So you also have your immunity. So the immunity, in fact, the data shows that a third of the HPV-infected patients will persist beyond 6 months. And immunity will sometimes cover this even after 1 to 2 years. Now, the next question the patient will ask is that, well, if I'm triggered by HPV, how about the other cells? Well, you have to educate the patients. This is now an era of education. Patient comes into your clinic that's really well researched. And you have to reorient, reformat, or redirect their thinking and say, look, not all HPV-infected cells will go to cancers, okay? It's a balance between the oncoproteins that the HPV produces versus your immunity.
But if you do test positive for HPV, and it doesn't necessarily mean that will turn into cancer, but should you be monitoring yourself more closely or looking for signs more diligently because you know that it's a possibility? Okay,
for the HPV monitoring is that it's still being researched. In fact, Hopkins is doing a study to determine what's the best screening technique for that. That's not yet answered, okay? My suggestion for patients is that there are signs and symptoms that you should have to take into consideration, especially if you're sexually active, heavy on alcohol, heavy on smoking, or combination of both. And you can always go to, this is where interesting.
How about if you were? I mean, we are all children of the 60s and 70s, and right? So maybe in our 20s, we were a little risky.
Okay.
I'm not saying, I'm just saying, right? So does but you're living a very healthy lifestyle now. Does it matter if you did those things?
Well, again, it depends upon your immunity and your risk factors. Now, the first data that came out by Ang et al. In New England Journal of Medicine says that if you have a smoking history of more than 10 years, you're already at risk. Okay. Some data says that if you reduce your smoking or even stop smoking, the risk goes down, but the risk is still there. Okay. Now, it's a balance between, you have to tell this in your patient in a layman's terms, you have to be a balance between your immunity to fight versus your risk factors. And you lose nothing by doing a healthy living.
Right. Help your immune. All right. So we've hit one of the questions that we have a lot of questions, and I want to make sure we have time for them.
Sure.
Because people wrote in earlier and wanted some answers. And the first one had to do with what we were just talking about. And Candy writes, since routine screens are not conducted for head and neck cancer as they are for, say, prostate or breast cancer, right? What is the most effective approach in examining oneself, if that is even possible?
Good question. In fact, that's a very common question by patients come into the clinic. Well, the first thing is that you really have to sit down with your patient and educate your patient. What are the signs and symptoms that you become worrisome? One, you have a white patch that doesn't want to go away. The operational keyword there is persistence of symptoms. If you have persistent symptoms, usually they will come into primary care will treat them, there will be no response, then you need to have to examine that. So that's one, persistent.
So for example, a sore throat that doesn't go away.
Yes, if you have a sore throat that doesn't go away, and the primary care physician and your colleagues in the medical field did their best and they're still persistent, that requires an evaluation. And having said that, you have to think also of the risk factors there. And are you a smoker, drinker, and so forth. Other symptoms of head and neck is lumps in the neck, okay? Not all lumps in the neck becomes cancer, because when they have the common notion when the patient, oh, I have a neck mass, I have the symptoms, they will do the research and they will come into the clinic and say, I have cancer. That is very common right now because of the internet. Actually, it's an advantage. I do not see that as a disadvantage. Why? Because that means to say your patient is trying to educate him.
Right, and they may come in alarmed.
Yeah,
but
then you can redirect that saying, look, these are the things you need to watch out. This is the website you need to look at. So you direct them to that area there. My life becomes easier when they read that, so that when we discuss these things, it becomes patient, pathology, procedure, performance status, pastoral. So what are other things? Like, for example, sore throat with pain in the ear. And the question is, why is that having ear pains? Well, remember, if you have something in your throat, it's referred pain to your ear.
But it could also just as easily be TMJ or...
Yes, yeah. That's why you have to differentiate. Your dentist is also going to do your routine annual dental will help. And our dentists in our dental community are very, very sharp now in picking up these things. If they are in doubt, they will refer them either to a head and neck service, either general surgery based or ENT based, or they will just go to an oral surgeon and further evaluation. There are avenues.
So this is also more motivation to get your regular dental checkup.
That's true.
But if your dentist isn't doing some of these things, what are the things that you should know that your dentist is doing? Looking under your tongue, looking at the roof of your mouth, what should your dentist be doing?
Well, your dentist will usually do their standard dental examination before they do anything else. And if they see out of normal, like for a white patch, they will ask you if there's a red patch there, if there's an irregularity in the lining, if there's tenderness, there's numbness there. Those are warning signs that it has to be evaluated. Now, as a patient, that's why when a patient comes in, they said, I live far away from GBMC. So a good question. Actually, as a patient, you have the right to ask your doctors. And I promote this because if the patient doesn't understand what he's having, the treatment paradigm becomes more difficult. So you have to tell the patients, look, it's your right to ask questions. And the doctor should not be offended, because it is also his duty, my personal opinion, it is his duty to answer those questions. So it's a give and take. It's a give and take.
I love that, Dr. Blanco. You're very focused on sort of the whole patient, not just what is happening in the head and the neck, but really the whole psyche of the patient. Another question, who is more at risk for developing head and neck cancer, men or women?
Now, if we go to the statistics, I will give you the range. It's 6 to 7, even 4 to 7 males to females ratio. 6:1 or 4:1. Especially for the HPV. The HPV data says males are more commonly affected than that of the females. So a male patient will then come in, am I at risk? I said, what are your symptoms? Patient will come in and will focus on one symptom, and you need to explain and expound that so he or she understands that.
Great question, and where we probably need to go next is, how do you make the diagnosis? I mean, I know you said you could have a lump, you could have a white patch or a red patch inside your mouth somewhere, but then you have to take it a step further.
Yes. So when the patient is really, remember, the patient is already anxious. You don't know the socioeconomic status of the patient when they come in. On top of that, there's a high index of suspicion for malignancy. So you have to...
Wait, they have a high index?
No, what I meant is that the patient comes in referred to you with high index.
Oh, okay. By the time you see them, there's something going on.
So there's already a lot of things going on there. So you need to refocus and again be patient-centric. You have to tell them, I understand that there are things in life that is going on there. And they will tell you they're in clinic. That's my thing. However, we need to refocus. In order to treat you, we need to have a black and white report saying that this is benign, this is malignant. And how do we go about it? And you explain it. There are several ways. You do a punch biopsy, you do a needle aspiration biopsy, and sometimes, if necessary, you have to do an open biopsy. So patients, there is a comment by one of my colleagues. He said, for a patient who is high probability of cancer and not knowing it, it's like anxiety, eternal anxiety. You have to allay the fears there. So how do you allay the fears? Knowledge, reassurance. So you tell them, look, the biopsy, the needle biopsy is about 90 to 95% accurate. However, there is a chance that it can be false positive, false negative, or inconclusive. Then you go further and you say, if it's inconclusive, what are we going to do? So you can either repeat that, you can do either the open biopsy. So you more or less given the patient a pathway. So it allays his fears. What's next? What's next? And then what I call the what-if scenario.
Until you have a definitive answer.
The what-if scenario, some patient will come in what I call the what-if scenario syndrome.
That's me, by the way.
So the way I break that is that I will let them speak and they say, okay, I understand your concerns, but what is your evidence or your black and white evidence for this? It's not 100%, 50% will say, okay. Some percent, they will still continue. So if you have the report there, then you can move for treatment. So you prioritize the first thing that comes in, unless they have a diagnosis when they come in. So let's assume that the patient doesn't have a diagnosis. You have a high index of suspicion. You do your biopsy, whatever form, non-invasive or invasive. Then you get the black and white report. And I personally give the report to them so that everybody understands. And I prefer family members to be there. Why? Because confusion comes in.
Oh yeah, you don't even hear if you're the person.
Not only that, because if ever this patient is diagnosed to have cancer, he will need support. And one thing I notice in my practice is that when you sit down with the patient alone, there's a study that the range of person retaining what you said is they actually not able to retain in 40 to 80%. So that's a problem for me. That's why I always invite patients, family members to come in. So there will be one channel, one page, and everybody understands that. And sometimes you allude that, look, your relative is suspicion for cancer or diagnosed of cancer. You need to support the person.
Right, and also hear the facts I'm about ready to tell you.
Yes.
So I want to get a question from the crowd in just 1 second, but I just want to ask this because it just seems like the natural way to go next. What are the treatment options? I know it's probably different for everything, but...
Okay. So treatment options can be divided to surgical and non-surgical. Okay. The surgical, it can be open, robotic, or laser. The non-surgical options will be radiation with or without chemotherapy. This is more or less a generalized view for head and neck cancers. Now, there is several parameters which way to go. This is when you sit down with the patient. And do I have time to explain this?
Well, I think what you're getting at, if I'm not mistaken, is what are they willing to do based on the life that they see for themselves?
Yes.
Is that right? Okay.
So the decision making, whether you go for, it's a very good question actually. That's a very common question. When they come in, they already researched it. Sometimes they come in with a paper. Sometimes they have already researched it. They have already their own questions. So when you come in, is Dr. Blanco, is this going to be surgical or non-surgical? Okay. So you have to explain the process to them. Because when a patient research, it's going to be more or less, unless they go to a specific website. That's why, as I've said earlier, it's an advantage. You go to this website, you go to this American college, this academic center, so that it formats their thinking. So to me, the way I run it is 5 Ps: patient, pathology, procedure, performance status, and pastoral. Patient, you have to think of a patient as a human being, not as a statistic. You have to consider the socioeconomic factors and the emotion. Pathology, that has to be proven. Cardinal and absolute rule. Before you do treatment for cancer, you have to prove it's cancer. Then you have to think about the performance status, which is the quality of life. Okay. So the 3 Ps are already there. Then we go now to the procedure. It can be surgical and non-surgical. And I tell the patient, we have to present this in a multidisciplinary conference, which is made up of all specialty involved in head and neck. It is more or less a second opinion or a discussion of your case. So once the multidisciplinary conference has been done, you presented the case, that is it's not absolute. It is a recommendation. Then you talk it out to the patient, look, this is your case. This is what we found out. This is what the recommendation. And based on this, what do you think you prefer? This is our recommendation. Why do I say that? Because you cannot dictate. There's such a thing as patient bill of rights. If you review that patient bill of rights, he has the right to decide which way to go. Okay? So then you decide which way to go. And sometimes if the patient is still worrisome, he said, look, you're still deciding, we're still on the process. You ask them to see your colleagues, medical oncology, radiation oncology, to get the opinion, then make it. And once they have the opinion, it's a non-biased suggestion. Once they have that, then they make the decision for the procedure.
Based on your recommendation.
Yes. Then the last thing is P, the pastoral. Why do I say this? Pastoral means to say you have to think, you must give hope to these patients. You're going to come in, well, this is cancer, so forth, so forth. This is what you're 5 years old. No. There's a famous head and neck cancer surgeon in Australia who actually died. And before he died, he lectured on us and in the American Head and Neck Society. And his last message is, for head and neck cancer, you make sure that they have hope. So that's pastoral, that's holistic. That's
for any cancer,
yes.
Wouldn't you say?
Mindfulness, spirituality, and everything, anything that will help the patient.
Right. I want to take this question from the crowd, sorry.
Hi, so we have a question from somebody regarding the risk factor of smoking, that you had mentioned that it was over 10 years, and she wanted to know if that was pack years or calendar years.
It's actually calendar years, 10 years of smoking there.
No matter how many packs a day, I guess.
Okay.
There are studies that use pack years, but usually I'm basing it on the medical literature first established by Garson, the Ang and colleagues, that they use 10 years of smoking.
So you talked a lot about working with the patient to make the best decision on moving forward,
yes,
if they are diagnosed with head and neck cancer. And you talked about hope. And I just want to cut right down to it and talk about what is the hope? What is survivable? What's considered survivable? What are the prognosis?
Okay, so the question of a patient will come in is, I'm going to be alive 5 years from now? So it goes back again to pathology. Under the P pathology, you give the stage. The stage will dictate the prognosis, okay? And the stage will also help the patient cope that this is what he's faced, okay? That's where other team members will come in, okay? Even the problem is if you give a survival data to the patient, they will obsess and think about the thing. I tell them...
But if you say stage 3 thyroid cancer, they'll get online and they'll research, they will come up with a lot of that data. We all have these preconceived notions based on fact and based on rumor about certain cancers. Colon cancer versus, let's say, pancreatic cancer. And with colon cancer, I think we're all pretty well aware that the earlier we catch it, the more survivable it is. 5 years, 10 years. Is it the same with head and neck? The earlier, the better?
Yes, it is the same. The earlier, the better.
Okay.
Okay, that's why the push right now for the American head and neck.
And earlier is possible with head and neck, I guess, because some cancers don't.
Yes, it's possible. Sometimes they will come in, look, I have a pain here in the buccal area, and you look at it and they say, okay, there are mucosal changes.
Okay. So get right on it, I guess, is the motto. Thank you so much. I wish we had more time. You have a fan club in the audience, and you can give him a round of applause if you want to. I think he deserves it. Dr. Blanco, but you know so much about this area, but I think the other fascinating and really important part is that you really are looking at the whole patient and it's not just about that one cancer, your expertise. It's about everything that they're going through and
Yes.
the family's going through. So I appreciate that. I think your patients obviously appreciate that.
Thank you very much.
Thank you. Thank you for joining us.
Okay.
And we're going to make just a little switch and talk about, sort of what happens during treatment, what happens after treatment, what kind of rehabilitation you might need or many people need. And that brings us to Jessica Maloney, who's joining us now. Hi, Jessica. Good to have you on our show again. Jessica is a speech and language pathologist, GBMC Health Partners, and Milton J. Dance Head and Neck Center. And yeah, we think of the head and neck. It's all about, talking and eating and speaking and singing maybe, or all of that. Such important things to our quality of life, particularly swallowing, I think. Such a big, big thing. So let's just talk about the role you play. I think when we think of head and neck cancers, we always think of the treatment, chemo, radiation, surgery, how we're going to deal with that. But sometimes I think people don't even get their heads around exactly what comes after that. Okay, so we get the surgery, we have the chemo, we're done with the radiation. Now, where are we, and how do we move forward and really try to get back what we had as much as possible?
Yeah, our main goal is restoring function after whatever kind of cancer treatment goes on to hopefully get rid of a cancer. And picking up those pieces can be a tall task, but we have tools and we have ways of doing that. And the goal is to bring people back to to help people establish their new normal and try to get people to a very functional point. And depending on the extent of the cancer and the extent of the treatments, we just pick up wherever that may be afterwards and during even. To try to keep people as functional as possible throughout those treatments and then far into survivorship after.
And is it possible that the new normal can also be the old normal?
For some people, yes, but most people will tell you that they're not quite back to the way that they were.
Okay.
Yeah, there's always maybe a little difference here and there. It becomes a part of who you are. We just try to help people feel as though it doesn't define who you are after having head and neck cancer.
I know this, I hate to use absolutes because there's always an exception, but do you see most head and neck cancer patients after their treatment?
Yes, at the center, we try to intervene early on. So
even during treatment?
Even during treatment, and even before in a lot of cases. Yeah, so Dr. Blanco referenced our conference, our multidisciplinary care conference, and we all meet once a week to talk about new patients and to also talk about active patients undergoing treatment. And that's an opportunity for all members of our multidisciplinary team to sort of catch up, communicate with each other, provide updates, and have everyone understand where each patient is at. And that is essential to caring for head and neck cancer patients. We're all able to have very open dialogue and provide updates, like I said, and help get each patient what they need to get them through their treatment or further along in their recovery.
So this is the team approach, but I also call it the village. Everybody needs a good village.
Everybody needs a good village.
So would you say the most impactful issue when it comes to head and neck cancer is swallowing?
Certainly a big one. Eating and social aspects of eating are so essential to quality of life, like you said. Survival, participation, being a part of things. There's a lot that goes on around a table. I grew up in a family that had dinner together every night and big family, loud family gatherings, food for everyone. And I think part of what drew me to this part of my field is that I hold that very close to me, and I understand the importance of that. You think that everybody knows the importance of eating, but until you're faced with challenges with that, I think, unfortunately, it's something, myself included, that gets taken for granted.
Can we talk about what some of those challenges are?
Sure. So oftentimes patients who have surgery to treat their cancer end up with deficits either in the ability to manipulate food and drink in the mouth, or changes to the anatomy of the throat that can impact how things move through the throat or not. And then patients who are treated non-surgically with radiation and with chemotherapy potentially in some cases, those folks are at risk for developing some trouble as well in a different way. We're not altering their anatomy per se, but their function can be affected by those treatments.
So what would impact sort of having to eat very slowly, having to eat certain foods?
Sure.
Actually can't swallow, or you're coughing up or aspirating?
Yeah, symptoms of swallowing problems, there's a pretty wide range, but yes, we think of sort of the coughing, choke, you're in a restaurant, you hear someone start coughing and you kind of look, ooh, are they okay? Are they breathing okay? So yes, coughing, choking, things potentially going down the wrong way, things getting caught in the throat, you really need to wash that down, or a lot of it's stuck in my mouth and I've already swallowed, there's still leftovers there, what do I do with that? So yes, it's a combination of things. First, identifying the problem, figuring out how to address it, which might involve some troubleshooting, some diet recommendations, maybe avoid these things, stick to these things, but then also rehabilitation and trying to build strength and improve function for...
It sounds like mindfulness is a huge part of it too, because how often do we eat? I mean, we eat too fast, or we're not paying attention on a normal day, right?
Sure.
And we can end up choking or coughing, or it goes down the wrong way.
Yep.
So it's like thinking and slowing down and really making it a point.
It becomes much more of a deliberate task when there's an impairment there or a difficulty there.
Is this, when you see these issues, how much progress can be made? And I know this is patient-specific.
Oh, yeah, absolutely. Patient-specific. It really depends on the issue. So first we need to identify what is it. And the way we do that is by doing some type of evaluation. We have the ability to evaluate patients, sitting next to us and observing them and checking for certain things, but we always do thorough evaluations of muscle movement and strength and function. We have more objective ways of looking at swallowing, either with the use of cameras or x-ray. And we sort of decide based on the patient what makes the most sense, what tools to utilize in the evaluation process, and then that helps us to guide our treatment.
Do you actually, because I've been to, I've been to physical therapy before, occupational therapy, but what do you do for swallowing therapy or head and, do you actually have them do exercises in your office?
Yes, yep, we do, and it seems foreign to the mind to think about, but the same way that you can do reps with a dumbbell to build your bicep, you can do reps with muscles in your throat to help with your swallowing. So yes, exercise.
Should we be just, even if we haven't struggled with a cancer diagnosis or working past that, should we be more aware of how we eat and swallow on an everyday basis? I mean, are you appalled when you see someone shoving down a 6-foot sub really fast?
No, I'm guilty. I do that. You see me out there. I would say just be aware of what's normal for you. And, the general theme here has been if you're noticing a change, a persistent change, it's something that's not getting better with time, that's when you want to pay attention to that and have it looked at. Mention it to one of your providers.
Okay. We have a question from Karen, who wrote in and said, certain medications and autoimmune disorders like systemic lupus can cause hoarseness, dry mouth, and throat. What are the best ways to address this to get relief?
Yeah, so issues with dryness for anyone.
Oh, and not even, let's just say you have reflux, or there are all kinds of issues that can come up besides
but lots of things that can cause irritation and dryness. Just sort of some general good habits are improving your hydration as well as humidification. So we know drinking water is important, just kind of continuously throughout the day, sips here and there. Probably take one now.
This is water, by the way, not tea or caffeine.
Yes.
Which we heard earlier from John and Dan, right? That I thought it was so interesting because I have a husband who sings and he will do hot tea. Bad, right? He said that.
Yes. So, there is water in tea, but there are drying properties as well.
Right.
So clear liquids of any kind in general can help with hydrating, but you can't beat water. Ways to improve humidification, anything to introduce moisture. Our nurse in the team says, leave the hot shower running for an extra few minutes and just kind of breathe some of that hot, moist air. Set up a little bedside humidifier that allows more direct moisture to hit the air you're breathing rather than the one that sort of filters your entire house. Nasal saline rinses, little spray bottles, over-the-counter hacks for improving humidification, hydration can help with a variety of issues.
We need to stay moist.
Yes.
Michelle writes, hi. Hi, Michelle. I'm a singer and I've noticed or experienced trouble with my voice. It always feels like I'm straining to sing. That's really worries a singer. And by the way, in my line of work too, we got a cold or couldn't talk. You didn't work.
Yeah.
Could there be some type of nodule on my vocal cords? I've had my throat checked many years ago. Can't remember the results. Can you offer a suggestion for this issue or a test specifically for a problem such as mine?
Yeah, I think that the best bet would be to be evaluated by an ear, nose, and throat doctor, particularly someone who specializes in voice, if you're a singer especially, and to have an evaluation to look at the vocal cords and study the vibration and the movement and make sure or identify what we think is underlying that issue in order to help figure out how to treat it.
We talked a lot about the swallowing, and so while we're talking about the vocal cords and the voice, I'm sure people come to you after they've had head or neck surgery or what have you, and they have issues talking, their voice, maybe it hurts even.
Sure.
What do you do for that?
So there are, just as there's exercises for swallowing, there are exercises for voice. With any intervention or therapy we're going to provide, evaluation is the first step, no matter what. And that's to try to figure out what exactly is the issue. Okay, so the complaint is hoarseness or pain, but why do we think that is? Maybe it's a result of the surgery and it's still healing. Maybe it's a result of the radiation and your body's still recovering from that. But once we have a handle on what's going on, we're able to guide our therapies and perhaps, you know, a combination of voice therapy and swallowing therapy, whatever, tailor it to the patient's
So
needs.
I'm going to ask you, what is one example of a voice exercise? Can you do one?
Can I do a voice exercise?
Like
sure.
what would it be?
We could do just sort of a very basic exercise to help find a more forward focus with your voice, meaning trying to take some of the effort out of what's happening at the level of the vocal cords and make a little bit more of a resonant sound. So we'll just do a very basic hum and try to feel vibration anywhere up here. So lips, nose, cheeks, wherever you feel any vibration in use, and just at a comfortable pitch and volume, you can just hold out. Try to get a little bit of like a nasal sound.
I do feel a vibration.
Good, great. Where do you feel it?
In my mouth.
Nice forward focus. That's excellent. Very healthy posture there.
Okay, so that's what we want. We want to feel that coming forward. Some
Yes,
kind of
and
vibration.
there's that was just like a little 2-second
Right,
thing,
but how many times would you do that? Like,
I mean, a few
all the
times.
time?
No,
in the car?
not all the time. A few times, but there's lots. All of the therapy really builds on itself. So we kind of introduce at the foundation level, build on things with the overall goal of helping you generalize to using good habits all throughout your day, far outside of the therapy session.
All right, that's interesting. Linda writes, I may be unique in this, but at 5 years, don't you think that's 50 maybe? I don't know. At 5 years, I'm still having swallow and speech problems. Maybe it's been 5 years.
Okay, yeah.
That's what it is. I was like, she's not 5 years old for sure. Is this common, and how much can swallowing and speech be improved?
Yeah, so not uncommon. We see a lot of patients who are 5, 10, 15 years out from head and neck cancer treatment dealing with issues related to speech and swallowing. And, you know, it doesn't happen for everyone. And again, it really just depends on where the cancer was, how it was treated. And we see it though. And there's a good percentage of folks who come back, even if they were doing really well for a while, after 5, 10, 15 years and say, gee, I was good for a while, but I'm starting to notice some trouble. And in those folks, we get down to it with rehab again. And maybe some of the same things we used years ago as they were going through their treatment become more relevant again now, even 5, 10 years out. So I'd say that for Linda, seek evaluation. Let's figure out what's at the root of these issues and then find a way to help improve it. And a lot of times we are able to get some functional improvement.
There's help out there.
Oh, yeah.
Question, John?
Yeah, we have a question from a member of our audience. The question is, are there speech problems too from head and neck cancer?
Yes, there certainly can be speech problems. Dr. Blanco was mentioning a little bit about the different sites of disease, and a lot of times it's the sites that are in the mouth, the tongue especially, that can impact speech. So that's sort of the greatest at-risk site for cancer to have an impact on your speech, but dryness and other factors can also affect your speech, whether your cancer's on your tongue or not, and we can work on those things as well.
Do you see other types of patients besides cancer survivors, Alzheimer's, Parkinson's, any kind of an issue that would affect?
Sure, yeah. Our center, part of the center is the head and neck cancer group, but we also see patients with neurologic conditions and other issues as well, and provide similar treatments to those folks.
Mostly older in age, or does it run the whole gamut?
For head and neck cancer,
Yeah,
just in general?
in general.
Yeah, our head and neck cancer patients are getting younger with the onset of HPV-related disease, as Dr. Blanco mentioned. But we see folks in the 40, 50, 60s, 70s, beyond even. And yes, but in general, our center sees folks from premature babies all the way up through geriatrics for various issues.
All right. Thank you so much
for
being with us today again, Jessica Maloney. And we appreciate it. And you were talking about the Milton J. Dance Head and Neck Center, where I know you do a lot of your work. But there's another portion of GBMC that's so fascinating that John talked about a little bit earlier, and it really focuses on the voice. Yes. And it is the Fender Voice Rehab Center. And our colleague Don Scott took a visit and takes us there.
You have surely heard the name Fender if you're a fan of rock legends like Jimi Hendrix or Eric Clapton. But what you might not know is that those iconic instruments also have therapeutic uses as well. The Johns Hopkins Voice Center, located at GBMC's Milton J. Dance Jr. Head and Neck Surgery Center, mends damaged voices of all kinds, sometimes with a little help from their friends at Fender Musical Instruments Corporation. I met with Barbara Messing, the director of the Dance Center, and Dan Sherwood, a speech pathology clinical specialist at GBMC, to find out more.
This is where we work with musicians and singers and people who are fronting bands, and we get a lot of indie singer-songwriters, high school and elementary school music teachers. So we try to simulate their environment as much as we can, and they feel very comfortable here. So this is where we work with our professional voice users for the most part.
And I guess nobody has to bring their own guitar, right?
They often do, though. Sometimes your own axe is the best thing, and we can set up on different type of microphones and work with them, and so we can again simulate what they do, and kind of tweak the biomechanics and the technical problems that may be contributing to their vocal issues.
Explain to us how Fender's involved and where you got all this great stuff.
Yeah, they were kind enough. We had a connection through one of the doctors. Explained to a Fender representative that became our Fender representative that what we wanted to do here as the Voice Center grew, and what we were doing to cater to more vocal professionals and performing artists, and it just all came together over time. And Fender ended up donating about $20,000 worth of all the gear you see here, all the guitars, amps, percussion, harmonicas, a ukulele. We've got a little bit of everything. They were very generous.
Can you tell me what a typical professional singer, let's say, what kind of problem are they having, and how do you fix it?
Often there's just a lot of wear and tear in the vocal cords. That's what we see. They don't have any overt pathology that we have to surgically remove. Sometimes they do, but often it's just a technical issue working around a lot of wear and tear, like, we get little bits of arthritis and wear and tear and rotator cuff and things like that. If we're active adults, well, singers, they're the athletes of the voice world, so they get wear and tear in the cords, and we have to learn how to work around that. Sometimes they do get overt pathologies that require surgical care. Sometimes we can see them and help them avoid surgery, just again, working out technical issues and using their body as their vocal instrument, not just their throat.
What would a regular person come in for?
Well, there's a lot going on here. Vocal rehab for all kinds of voice problems, not just singers and professional voice users, but anybody who we all have a larynx and we all talk, we all use it, and anything can happen. You can go to the Ravens game and scream your head off and blow a blood vessel, and next thing you know, you're still hoarse 2 weeks later, and you come in and we have to fix it. And so we have that. We see a lot of school teachers who talk for a living all day long. They're athletes vocally, and like any other athlete who demands more of their body than the average person, wear and tear, and we have to rehab them. So this place is very busy in the summer with school teachers who are off, dealing with voice problems, getting back in the game for fall.
One of the greatest things about being retired is I can yell at Ravens games on Sunday afternoon now.
Yeah, true. Just be careful.
The Fender Music and Voice Studio is just a small part of the Voice Center's 5,000 square feet of real estate.
The purpose of the Voice Center is to help patients with voice disorders. We diagnose, find out what the problems are, and then we have a multidisciplinary team of laryngologists, voice clinicians, specially trained clinicians to work with the voice problems that they may have. So we were able to evaluate, medically manage, and also behaviorally treat. So it's a full continuum of care for patients with any kind of vocal problems. We do a lot of office-based procedures. For example, when someone has an aged voice and their vocal cords may become thin, and there's different procedures we can do to kind of plump up the vocal cords and help them be the patient have a louder volume and a better voice production.
Like an injection? Or?
Correct, and we can do that right here in the office.
So that's medically?
Right, and there's different surgical procedures for removal of polyps and things like that that may grow on the vocal cords. Behaviorally, that would be voice therapy techniques that the voice clinicians would do with the patients.
And what kind of thing are we talking about there, voice therapy?
How to take care of your voice better, how to make sure you stay hydrated. Patients will learn vocal function exercises on things that will help mobility of the vocal folds and help the tissue to be healthy, and also to make sure that they don't have a strong impact when they're talking, so they're not slamming their vocal cords together. So maybe easier onset, breath control, making sure they have proper posture and breath control to produce voice more efficiently and effectively.
You're going to make me sit up now. The innovative Movement Education Studio is designed for body-centered therapy used to enhance body awareness and promote the physical freedom necessary for vocal flexibility.
And the whole philosophy is voice is a product of the body, not a product of the throat. A free voice cannot come out of a tight body, and especially with vocal athletes, because they're often in shows that require a lot of movement, dancing, strange positions, heavy costumes, cumbersome sort of things. We have to help them with chronic aches and tensions that develop, head, neck, spine issues. So we have a whole movement room next door to this one where we have a massage table laid out, and we have exercise balls and various types of equipment and bolsters to help people relieve chronic nagging aches and tensions and all over the body that can affect free, easy voice production.
Happy sound can't come out of a sad grimace either, but...
We can fake it till we make it.
So, if you need a voice mender, come to Fender and Dance Centers at GBMC. I'm Don Scott.
That's a very cool place. One of the threads, I think, a common thread through all of this is that we've been talking about sort of the whole patient and just a multidisciplinary approach, which is very indicative of the sort of the culture, I think, at GBMC. But so joining us now in that vein, is Dorothy Gould, who is a licensed social worker, and she's at the Milton J. Dance Head and Neck Center, and one of her favorite, if not her favorite, patients, Tom Ellis. Wait, do you have other patients here? Oh, no. One of the many, or they're all, yes. If they come to you, they're your favorites. So thanks for being here, because there's nothing like hearing the experience from a patient point of view. But I think when we think about any cancer or any health issue, we forget about what role the role of somebody helping our emotional and mental health during the whole process. And it was obvious to me that this is very important to Dr. Blanco and everyone else on the team, that we look at the whole patient and what they want their lives to be and what they uniquely will have to deal with. So can you just talk, what is your role there, and what do you do?
So I am an oncology social worker. I specialize with oncology patients and actually work in the Head and Neck Center with all the head and neck cancer patients. So that's a very unique specialty, to be able to concentrate on one type of cancer. We all know that the diagnosis of cancer is a shock, and for some people, that shock can be overwhelming, and so the support is really important. So that can start right from the beginning, usually from the surgeon. And I like to joke, I think Dr. Blanco's gone, but sometimes I'll get a call from his medical assistant and say, Dr. Blanco wants you in room 2. And I'll go, oh, you have a crier, huh? And it's funny, but he's aware that somebody is really overwhelmed by that, by the thought of having the cancer, what is going to happen to them, what's their mortality, what is their life going to be like, what is their family's life going to be like. So going in at that moment, even just for a few moments, to introduce myself, to let them know that support is there, to let them know that I understand their shock and that they'll be followed as they go through this journey of uncharted territory.
In case your mouth is a little dry, and we're very sensitive to that during this particular conversation. We want to bring you a little bit of water. Thank you, Mindy.
So that's the first, but we also, as you said, work as a team. So we try, all of our patients are offered to meet with the team, which includes head and neck nurse specialist, social worker, dietitian, and speech language pathologist before they start their treatment, where we kind of go over our roles and what they can expect. And that's also a way to relieve their anxiety and then to follow them through the treatment and through the recovery.
And Tom, I'm sure as you're listening to this conversation, as you were listening to Dr. Blanco, this took you back a couple of years.
Yes.
Can you just tell us your story?
Well, I was actually misdiagnosed for 3 years by an ENT. The lump in my neck, he thought was, he treated it as a blocked salivary gland. The solution being eat hard candies to salivate and massage it, and it will get better. And this went on, and I kept questioning, do we need to do more? And then luckily I have a wonderful general practitioner who 3 years later was doing a physical and felt that and said, what does Dr. So-and-so say about that? And so I shared with him, he said, I think we need a second opinion. And I said, I've been very lucky in life, and luckily he sent me down to GBMC, and I saw Dr. Wood, and I was with him less than 5 minutes, and he said, I know you didn't come for this, but I think we need to do a biopsy, and he did the needle biopsy and wrote an order for a CT scan. I was back in his office like 2 days later. It was Friday afternoon at 4 o'clock, and he said, it's not a salivary gland, it's 2 lymph glands, and it's 2, not 1, and you're stage 4. So, and he said, don't worry about it, I've got you scheduled in at the Head and Neck Center Monday morning, and he said, let me call you.
Did he really say you're stage 4, and then he said, don't worry about it, I have you scheduled?
Said, I got you covered. So, and we went from there.
So as soon as you said that, I don't know if you heard the audience, but there was sort of this collective, kind of people can just imagine so I'm thinking where your role is concerned, what kind of support did you need at that point? Was it just surreal? Well,
it was sort of surreal. In fact, it was the one time that my wife was not with me. She insists on going, and I went home, and because she had something else to do, and I came in and said, well, how'd it go? And I told her, and she immediately started to cry and said, you're never going to another meeting without me. And so she didn't. And she was there every step along the way. So she was great support. And then the team was great support. I never felt like I was not cared for at any point.
And how much of a difference do you think that made in your...
All the difference in the world. And the thing I've often said about the team, and I was told what I could expect to happen. I was given all the different alternatives, and all along the way, everything they said would happen, happened. So nothing came as a surprise. I was never shocked at any point. And I'm very lucky. My treatment went very well, and I've said, call me Ned. No evidence of disease. I've changed my name. So at this point, things for me are quite good.
Wonderful. When things were difficult, maybe not for you, but maybe for your wife or other members of your family, how did Dorothy or other members of the team sort of prop you up, might be the wrong way to put it, but
I guess
you deal?
The interesting, when I did my radiation and chemo, every time I was there, especially on the days that I had the chemo, Dorothy or Jessica or somebody always showed up, and Jessica was always there with her, with her gauge to open your mouth. How big is your mouth? And my wife would say, it's big enough. You don't need to stick that gauge in there. But they followed me all the way through. They were always there. I never felt alone. Because that thing I've said about Dorothy is she has the unique talent of making you feel that you're the only patient at GBMC. It's a gift. It's a totally unique talent. You can't put it into words. And I always felt like there's not one other cancer patient at GBMC. I'm the only patient in the whole hospital.
So Dorothy, I mean, there you are. You must have a calendar of like who's getting chemo when and who's getting ready, and you're just working it all in, and every day must be different.
Every day is different because you can schedule. Let's say Tom had his chemo on Tuesdays, and I would know who was there on Tuesday. And the reason the day of chemotherapy is easiest is because they're there for 6 hours, whereas radiation, you're in and out more quickly. But one day somebody could have a crisis, you know, something could be happening. Somebody could be getting a bad diagnosis later, and so somebody could have been hospitalized unexpectedly, and so you want to be there for those patients. Not every day is like that, but I try to see the patients who are going through treatment, if it's chemo and radiation under chemotherapy days, at least once a week, and if they're getting radiation only, again, once a week. And when they're in the hospital, even though I'm not the discharge planning social worker, if it's our patient, I will go see them primarily for the support and for the adjustment, because again, there's things going on that are new and that are going to change their lives. So I think of Jessica talking to you about the swallowing difficulties. Well, they didn't know. They have to suddenly realize that they may not be swallowing the way they did before, or they have to work very hard to get back to that swallowing. And that is emotional as well as physical. So we would work hand in hand with those patients. And sometimes the speech therapist might say, they come in and all they talk about is how they can't go eat with their friends. So we would kind of set it up where I might see them first so we could deal with the emotional, and then they're more prepared to work with the therapist on the exercises. So we kind of have to work together.
I would imagine that even when you go to see someone, you're never quite sure what you're going to get, right? I mean, because this is a roller coaster ride, emotionally, particularly for many people. How do you help someone in crisis?
Well, depending on what if it's an emotional crisis, you know, sometimes a crisis can be practical, and you know, there are
things going on at home that you don't even.
Oh well, you know, some of them have families and they're worried about their children. They're worried about their wives. Once I worked with a mother who had 3 kids, and she was trying to do everything, and I just worked with her on developing a calendar and seeing who could help her with what and identifying those people. So we have so many people that say to us, oh, let me know if I can do something for you. Well, this is the time to be specific. So I tell that person, well, when they ask you that, say, I could use a ride on Monday and Friday, or I need someone to pick up my child. So that's practical problem solving that when you're overwhelmed, you can't do it. Otherwise, it's sometimes just being present and listening to them, normalizing, validating their feelings. And sometimes it's helping with coping strategies. So what can you do with this stress? And you know, Tom mentioned his wife had difficulty. And there are times that I might just see the spouse once a week because the patient is like, oh, I'm fine, but my wife needs you. And so we sort of need to know.
Which then is hard on you if your wife is having a hard time.
Right, exactly. And as we've said, we have younger patients, so now we have patients that have children. And a common thing comes up in the beginning, I haven't told my children yet. How do I tell my children? So the issues that can come up are just varied and very different depending on who the patient is, what the diagnosis is, and what the type of treatment is.
When you go through this and when you also help others go through this, really gives you a different perspective on life, doesn't it?
It does. Yeah. Life looks very different.
How so?
Well, I think you appreciate things a lot more, and I always laugh. At my age, I'm retired. I have the no.
You look like a young man to me.
I have the go-go years and the no-go years. I'm in the go-go years. The no-go's coming, so we are packing everything into the go-go years that we can because So you realize that there's a clock ticking. There's an expiration date out here. It makes you a little more aware of that. It's not like something you dwell on, but you realize you better take advantage of the time that you've got. Because mine, again, we were very active, and the only symptom I had was a lump in the neck. I had no other symptoms whatsoever. We were traveling the world. I was perfectly healthy, and boom, this hits. So I've always said, you never know what's growing inside you.
And that's not uncommon with head and neck cancers. Or to find out that it's stage 4, but to learn that it's treatable and curable in head and neck.
You could have been a social worker in all kinds of scenarios. What is it about working with this group of people that feeds you?
So, you know, people often that I meet or friends say, how can you work with cancer patients? It must be so depressing. And I like to say it's one area where when you're working with them and helping them, you really see that you're making a difference in their life. And you're either helping them return to their lives, accept their new normals, and do well, like Tom and
Is that the
his
hardest
wife.
thing, accepting the new normal, do you think?
I think to some extent, because my life, I do have a new normal. I have a partial dry mouth, so I tend to drink more water, and I tend not to eat as fast as I was laughing when Jessica was talking about shoving it down. I used to. I don't do that anymore. I now eat much slower. My wife finishes way before I do usually. You know, I have, because of limited saliva, I find myself using a toothpick, which drives my wife crazy. I'm sitting at the table using a toothpick.
Is she here, by the way?
No, she's not.
Oh, darn.
And hopefully she's not watching. So, yeah, I do have a new normal. It's very. I can deal with it very well, but it's different.
Do you get the sense, and I get the sense this was also a running theme, that always hold on to hope, that there's always hope within this center and within each individual person there?
And hope, there's different things to hope for, you know, so you hope for a full recovery, you hope for a good quality of life. And I just want to say that we also have a support group that meets once a month. Tom is a very active member of that support group, and that's where people that have returned to the community and to their regular activities, but they all share an experience that no one else shares with them, and those little new normals that don't seem that different to, you know, people on the outside, they identify it and they talk about it. They talk about how it's changed their life, and they support each other. And when we have newer patients that are just starting treatment, the ones that are like 2 or 3 years, they really give them a lot of support. And it's a wonderful, active group that I'd say is very satisfying. And as a facilitator, it's satisfying to me as well.
Thank you both so much for joining us, and Tom telling your story, and Dorothy, thank you for all you do. It's really been great hearing all about the Milton J. Dance Head and Neck Center at GBMC and talking more about head and neck cancers. Thank you.
You're welcome.
You and Oprah.